mind in this field. So ma'am, please come on the stage. Thank you, ma'am.
So very good morning. At the outset, I would like to thank the organizers, especially Dr. Ravinder Bansal and Dr. Pankaj Goyal for inviting me. I'm very happy to be here. So my talk is mainly on the histopathology, but because Amit just touched a lot on FNAC, so I've added a couple of slides on that. And I hope you will be there with me throughout the lecture and not, as soon as the pathology starts, don't go into this mode. Well, as far as thyroid cancer is known, it is not one disease, right? So it is a bunch of diseases broadly categorized into those which are follicular derived and those which are C-cell derived. The follicular derived have the differentiated tumors, and vast majority of the thyroid cancers that we deal with are differentiated. And on histology, we categorize them into papillary thyroid carcinomas. Those are tumors which show papillae and have papillary-like nuclei, which are very characteristic orphan Annie nuclei. And then we have the follicular tumors. These are follicle-forming tumors. They show on pathology follicular pattern. And then there are tumors which are oncocytic. They are very pink-looking tumors. The cells have oncocytic change. Then we have lesser or uncommon tumors, which are the poorly differentiated ones. They don't show features of differentiation. And then we have very fulminant and highly malignant anaplastic thyroid carcinomas. And that is something that clinically also you suspect. The patient comes gasping and the patient is so sick. In fact, we will always get a phone call that I'm sending an urgent FNAC of anaplastic. The patient is usually sick. So, and if the patient is comfortable and we give a diagnosis of anaplastic, they will say, clinicians are not going to believe it. So anaplastic is a really almost an emergency. And then we have C-cell derived medullary thyroid carcinomas, which are calcitonin producing tumors, which are different from the follicular derived. So the basic pathology still remains the same. And the intersection of pathology and surgery, there are three main decision points when you think or you come across or you interact with your pathologist. One is in the preoperative setting where your main question is whether you have to operate this thyroid nodule or not. And vast majority of the thyroid nodules are benign. Vast majority of them you see in every fifth or seventh patient, you'll have a thyroid nodule. You can't end up operating all of them. So which are the ones where surgery matters and which are the ones that you definitely have to take out? So that is where FNA or in some scenarios biopsy can help you. Then in the post-operative, you've done the surgery. The next is whether the patient has to be observed. Is it a low-risk disease? Or the patient requires radioiodine? That is a very big question and it requires a lot of discussion, and most of your answers will come from the pathology report. And the third scenario is when there is an unresectable progressive disease or a metastatic thyroid cancer where it's not a surgical disease, but you have to have options of whether you want systemic treatment, whether you need to do find any targets, any targeted treatment is available or not. And that is where molecular testing can also help you. So I've added a couple of slides of FNAC. Fine needle aspiration we get a lot of FNA. All the masses undergo FNA according to the criteria. And FNAC is reported by Bethesda system. So if your pathologist is not reporting by Bethesda system, you can encourage, because that kind of streamlines the language and it puts all that we see into a language that you can understand. So it is basically divided into 6 categories. The non-diagnostic one, if we give you a diagnosis of non-diagnostic, that doesn't rule out malignancy. It is not the same as benign. It just means that the material is not enough to say anything, right? So you have to repeat, you have to see what is the ultrasound findings, and you have to repeat. That means the material was not adequate. If we give a benign, there is an estimated risk of 0 to 3% malignancy, which is too low. That is patient safely, you can send, you can observe that patient. And most of the lesions which are benign are colloid nodules or lymphocytic thyroiditis. They can be granulomas, any benign pathology. And the risk of malignancy is negligible. And these are patients you can send home and you can tell them to forget this disease. And then there is an indeterminate category where you call it atypia of uncertain significance. They have an estimated risk of 10 to 30%. So it is still a low risk, but this is when the FNSA is indeterminate, where either the material is too scanty or the findings are not enough to call it neoplastic. You can't even call it a tumor. So you are falling short of tumor because the aspirate is not giving you enough features. The lesion, there are many lesions. There are again lots of benign nodules. Vast majority of them are benign nodules, hyperplasias, which will give you FNAC, which is slightly more cellular than the normal benign ones, but it is not as cellular as the neoplastic ones. It shows indeterminate or features which are inadequate to call it as neoplastic. So you may have a lot of colloids still, right? Or you may have some subtle nuclear atypia not meeting a criteria of PTC. So atypia of uncertain significance tells you that you can't send this patient and forget this patient. You have to still follow up this patient. You have to again repeat the investigation either 6 months down the line, or you have to correlate. If you really feel on ultrasound or clinically that this may not be representative, then you can repeat a little earlier. Right? So it has to be your sonography findings as well as your clinical findings as well as the anxiety of the patient. You will have to take a call and repeat a little earlier. But AUS means you have to repeat either a little earlier if your suspicion on clinical findings is more, or a little later down the line after 6 months. Half the times it again turns out to be benign, and other half of the times it will again turn out to be AUS, right? So this is an area where there is a lot of research and lot of push for also doing molecular testing to try to see is that AUS or indeterminate neoplastic malignant or not. So that is usually not required in majority of the cases, but that is another discussion. Then the fourth category is the follicular neoplasm. This is where where the aspirates are too cellular, and we can clearly say that this is neoplastic. Whether it is benign or malignant, we cannot say on cytology. I will come to that again, why we cannot say that. That is because these tumors are usually follicular tumors. They are the ones which require histopathological evaluation and features of invasion, which you can only see on histopathology. So these are diagnoses of histopathology. So they require a minimum of lobectomy, which is a diagnostic lobectomy, where the entire tumor capsule can be evaluated, and then you can look for features of invasion to call it malignant. So most of the follicular, even though we are able to say it is tumor, we won't be able to say whether it's a follicular adenoma or a follicular carcinoma, because that requires histopathologic evaluation. So lobectomy is the plan for that. Then there are suspicious for PTC or suspicious for malignancy. These are cases where the material is not good, but the nuclear features are present. There is a lot of atypia, which is quite significant, and you feel it is suspicious for papillary thyroid carcinoma, but the aspirate is limited because of either lack of material or poor quality. It's not a good quality aspirate. Or it is good, the lesion is such where it is not yielding too much good material. So, but suspicious, if you see, if the pathologist calls it suspicious, it usually 50 to 75% of the times, it turns out to be malignant, and these are the patients you can plan for surgery. And malignancy is where it's usually short malignancy. And malignancy doesn't mean only thyroid cancer. You can have lymphomas also, and you can have other malignancies also. Thyroid can be involved by metastasis also, by some soft tissue tumors also, but those are very rare scenarios. Most important is lymphoma, and FNAC does a decent job. It is able to separate out lymphomas from thyroid malignancies. So what the FNAC can do is it can diagnose PTC, it can also suggest if there is lymphoma. If there is lymphoma, then we need a biopsy after that so that we can characterize it. We can see whether it do immunohistochemistry, because that is essential to characterize what type of lymphoma it is. Then FNAC can also suggest medullary thyroid carcinoma, but it can be a difficult diagnosis because medullary thyroid carcinoma, FNAC, it can be very clear-cut in certain cases, but in many cases it can overlap with oncocytic papillary thyroid carcinoma. So it may not, every time pathologists may not be able to distinguish between an oncocytic papillary thyroid carcinoma versus medullary, because there is some cytological overlap. But most of them can suspect that either it is this or this, and you can do serum calcitonin in those cases. And in many cases, you can also give a clear-cut diagnosis. But it is always better when the pathologist on FNAC is giving a medullary thyroid carcinoma to get a serum calcitonin done, if it is available. So FNAC can help you. You may or may not have the exact diagnosis, but it can help you plan your management, whether to observe this patient, whether to repeat FNAC, or whether to do surgery. What it cannot do is assess invasion. So it cannot, all the diagnoses which are based on criteria of invasion, that cytology cannot do. That is why we have that category of 4A, which is follicular neoplasm. And it cannot very reliably grade tumors. So poorly differentiated thyroid cancers, you cannot make that diagnosis very accurately on FNAC. And it cannot predict, it cannot give you whether RAI can be given or not. That is something that you get, all those features you get on pathology. So core needle biopsy is not routinely performed, but it can be done when you are suspecting a lymphoma, when you're repeatedly getting negative FNACs, and when you are suspecting anaplastic thyroid carcinoma. So in anaplastic thyroid carcinoma, that can be made, diagnosis can be made on cytology. But on the additional value of needle biopsy would be that you can do immunohistochemistry, and you can do BRAF immunohistochemistry, for which targeted treatment is available. And also when the patient has another malignancy also, sometimes they have kidney masses also, or some breast mass, and you are wanting to distinguish whether it is a breast metastasis to thyroid or is it a primary thyroid, then in those situations, the first line is FNAC, but you can also, if the FNAC cannot distinguish between the two, then you can do a core needle biopsy, because then you can also apply immunohistochemistry if required. So where ancillary testing would be required, those cases you can do biopsy. But biopsy is not a routine. For follicular neoplasm, never do a biopsy, because again, you need the whole capsule, and that's a diagnosis made on resection, not on a biopsy. Okay? So I'm coming to my main topic, which is what are the changes in the WHO, the latest WHO. So we classify and we report according to the WHO classification. The latest is the 5th classification. And there have been a lot of changes because our understanding of thyroid cancer has improved. And in the latest WHO, what WHO has done, it has done two opposite things. It has downgraded tumors that we were overtreating, and it has upgraded tumors that we were undertreating, because we understand biology better now. So the first key change that WHO has done is that it has emphasized not on what we see, on the nuclear features, but rather on the biology, on the invasion. So thyroid cancer is no longer treated based on what it is labeled as or called, but what its biology is, how it behaves. So invasion matters much more now, and that is what the pathologist should be able to focus on rather than the nuclear features, right? Second, we knew about the poorly differentiated thyroid cancers. WHO has now expanded that spectrum. It has expanded them into differentiated high-grade tumors and overridden the differentiated. That whether the tumor is differentiated or not, you have to look at the high-grade features. So it is not the morphology, but it is the presence of high-grade features which is now important. So the high-grade spectrum from a poorly differentiated has now been expanded to include the differentiated high-grade tumors also. Then the squamous carcinomas of thyroid, they behave like anaplastic thyroid carcinoma. So if there is a squamous carcinoma that is arising in the thyroid, that is an anaplastic carcinoma. So that is included, and now we know that anaplastic carcinoma has to be treated urgently and also has targeted treatment. So these patients should not be missing that treatment because they are labeled as squamous carcinoma. So a squamous carcinoma arising in thyroid is anaplastic thyroid carcinoma. And medullary thyroid carcinoma, earlier it was believed to be one disease. Now we know that there is a high-grade medullary thyroid carcinoma also. There are some bad actors in medullary thyroid carcinomas for which we need to grade them. So now the pathologists are supposed to provide you a grade of the medullary thyroid carcinoma. About 25% of the medullary thyroid carcinomas are high grade, and they are much more aggressive, and that can be decided on the pathology. So let us see some cases. One scenario that we commonly see and which causes a lot of problem and confusion is when we have these follicular tumors. So this is an example of an encapsulated tumor. This is a tumor when we have completely examined it, is not showing any capsular invasion. This is showing a follicular pattern. That means the whole tumor doesn't have papillae, is only follicular. And it is showing papillary thyroid-like nuclei. So 10 years ago, until recently, we were calling these tumors as follicular variant of papillary thyroid carcinoma because they had nuclei like papillary thyroid carcinoma. So that was the basis of calling them follicular variant of papillary thyroid carcinoma. But now the WHO says you don't have to focus so much on the nuclear features. It is the invasion of the tumor which is important. So no invasion means there is no malignant behavior. So that is the most important thing. It is the invasion that predicts biology, not the nuclear features. So now we call all these tumors which are completely encapsulated, no invasion, after complete evaluation, non-invasive follicular tumors with papillary-like nuclear features, which are called as NIFT-Ps. So we commonly use this term NIFT-P. You can understand these are follicular adenomas, but they have papillary-like nuclei. So this confusion has been sorted. All these tumors, when we label them follicular variant of PTC, if they were large, they all would undergo total thyroidectomy. They would undergo, because of the terminology carcinoma, they would undergo radioiodine. So many of these patients got radioiodine, many of these patients got total thyroidectomy, and now it is very well established that these patients, lobectomy is enough. So NIFT-Ps or non-invasive, they have a PTC-like nuclei, they are non-invasive, and they have a RAS-like biology, which I will speak a little later, and they show extremely indolent behavior. So what is the most important word in this is the non-invasive. So that means these patients only require lobectomy, and this is a diagnosis you can only make on lobectomy, not on cytology, and these patients do not require RAI. The problem with this is that you need to make sure that there is no focus of invasion, and what we get many times is just two slides or 3 slides from thyroid. So you have to make sure that the pathologist, if he or she is giving NIFT-P diagnosis, that he has sampled your entire tumor. So WHO has introduced, because of this, WHO has created another category, which is the low-risk neoplasms. So there were benign neoplasms, which have no risk of metastasis or death. You had malignant neoplasms, which had a risk of metastasis or death. And now you have this category of low-risk neoplasms, which are very indolent. Their behavior is like benign only, but they have a potential for a rare distant metastasis. So these NIFT-Ps are still not given a clean chit and not merged with follicular adenomas as of now. We are hoping that with more data, they will merge with follicular adenomas. So these low-risk follicular neoplasms, which include not only NEFT-B, but also thyroid tumors of uncertain malignant potential. I am sure you hate this diagnosis, but this diagnosis basically means it does not meet the criteria of malignancy. The features of invasion are incomplete. So those behave like benign tumors only. They are very low risk. They have very rare or very potential risk of metastasis, so they have to be followed. But they do not require RAI or treatment like malignancy. So what has conceptually changed is earlier classification was focused on nuclei and we were labeling these as carcinoma. Now it is the invasion which is defining the behavior. So let's take the same tumor when it is invading. So if you have an encapsulated follicular tumor, and now it is showing capsular invasion, and it has follicular pattern and papillary thyroid-like nuclei. So these cases were also, these are follicular variant of papillary thyroid carcinoma. These were also called as because there were papillary-like nuclei. So we have labeled these also as follicular variant of papillary thyroid carcinoma. So before I go on further, I will have to explain a little bit of the biology of thyroid follicular derived tumors. Now we know all these papillary thyroid carcinomas as well as the follicular thyroid carcinomas. If we look at what we understand now, these can broadly be all the follicular thyroid derived cancers can be divided into two categories. Those which underlying have BRAF, they are BRAF-like, they have mainly BRAF mutation, and those which are having mostly RAS-like mutations. So that is the basic pathology, that there are two types broadly which are very different clinically as well as pathologically. So the BRAF-like tumors, they have look also different, they clinically behave also different from the RAS-like tumors. So the BRAF-like tumors, when you will see, when a pathologist sees that tumor is infiltrative. It has infiltrative borders, whereas the RAS-like tumors have capsules. They are nicely encapsulated, like all the follicular tumors, like follicular adenoma, follicular carcinoma. They have a capsule, and it is the invasion of this capsule or beyond this capsule that we call as carcinoma, right? Whereas the BRAF-like tumors, the papillary thyroid carcinomas, they are infiltrative. They're not capsulated tumors. So these BRAF-like tumors, they have the classical orphan Annie nuclei. They have these empty PTC-like nuclei. And it is these PTC-like nuclei which has screwed the whole classification for many years. Whereas the RAS-like tumors, the follicular tumors, they have follicles and they have nuclear atypia, but they don't have classical PTC-like nuclei. They have some subtle nuclei. So you can say maybe some PTC-like, some not PTC-like. All right, so they have nuclear atypia is subtle. And BRAF-like are the ones, like the papillary, they have a lot of lymph node metastasis, whereas the RAS-like have distant metastasis or hematogenous metastasis. So if you see, this is the basic pathology, that there are two types, BRAF-like, which are infiltrative, they are not encapsulated. They have PTC-like nuclei, and they have a lymph node metastasis, whereas RAS-like, they are capsulated, and they have follicular pattern, and they have subtle nuclear features, not so classical PTC-like, and they have hematogenous spread. So biologically and looks-wise, they look very different. So if we apply that same to this category of tumors, what was seen, this encapsulated tumors, which we were calling as follicular variant of papillary thyroid carcinoma because they had nuclei like papillary thyroid carcinoma, when they were studied, because they were causing a lot of confusion, they were studied molecularly, and with the knowledge that we already have, it was found that the follicular variant of papillary thyroid carcinomas are also two different types. They could see that they are two clear-cut buckets. One of them some of these tumors showed infiltrative pattern, they showed BRAF mutations, and they had lymph node metastasis, and they were behaving like classical papillary thyroid carcinoma. Whereas those encapsulated follicular variants were encapsulated follicular, and they were having RAS-like, they were having RAS mutations, and they were aligning with follicular thyroid carcinoma. So clearly, this was not one disease. This infiltrative follicular variant was PTC subtype, whereas the encapsulated was not PTC. We were calling it follicular variant of PTC, but it was clear from the molecular and the overall that this is not a part of PTC. So what the WHO has done is it has, so encapsulated FVPTC is now out of the PTC family. So this is what is the most important thing that has happened in pathology. So if you have the encapsulated, the thyroid tumors which have a capsule, which have follicular, they are RAS-like. They have RAS mutations or mutations which are similar to RAS. What we have to see in them is, are they invasive? Is the tumor invading the capsule, or is it non-invasive? If it is non-invasive, it behaves like follicular adenoma. You can call it a follicular adenoma with PTC-like nuclei, and that is called as NIFT-P. Whereas if it is invasive, then these are still called as invasive encapsulated follicular variant of PTC, which basically means they are like follicular thyroid cancers but show PTC-like nuclei. So hopefully in the next editions, this will again merge with follicular thyroid carcinoma, and you don't have to deal with this complicated name, right? So when we have an encapsulated follicular tumor, I would request everybody to wake up. So encapsulated follicular tumors, they basically are RAS-like morphology. They are differentiated. These are tumors which are radioiodine avid. They are the ones which respond to treatment. And basically what the pathologist has to tell you after complete tumor evaluation, the capsule evaluation, whether it's a follicular, is there invasion? Is there no invasion? If it is invasion, then it is a malignancy. If it is questionable invasion, then it is uncertain malignant potential. That is the patient you have to follow up, but do not have to give radioiodine. So the emphasis is now onto the invasion and biology. So this I think I have expressed. So PTC doesn't have a capsule, it is infiltrative, whereas encapsulated follicular tumors, the diagnosis of invasion on which everything is dependent is based on two things. Either there has to be a capsular invasion or there has to be vascular invasion. That is what is important, and that is what the report has to mention. So capsular invasion is when the tumor goes completely out of the capsule. There is no incomplete. It's not in the process of invading. It has invaded beyond the capsule. So tumor penetrating through the entire capsule, that is what is labeled as, this is how you see a tumor mushroom. This is the capsule, and this is the, oh, you can't see a pointer, sorry, it's okay. Maybe here. So, laser pointer. So this is the capsule of the thyroid tumor. This is the normal thyroid, and this is what the capsular invasion, a tumor just mushrooms out of the thyroid. Here also you can see tumor mushrooming out and infiltrating into the adjacent thyroid parenchyma. So what the pathologist is supposed to provide you is the information that is the capsular invasion minimal or is it widely invasive? Because widely invasive is a high risk feature in the ATA, and widely invasive will usually be when the tumor is going much beyond its original capsule. Sometimes you can't see the capsule fully, and the tumor is also invading grossly into the strap muscles, into perithyroidal soft tissue. Usually it is associated with a lot of extrathyroidal extension, and this is a feature which is associated with high risk distant metastasis. So follicular thyroid carcinoma is not enough. The pathologist should also provide you the risk stratification, whether it is minimally invasive or is it widely invasive. These are some of the examples of widely invasive. This is the original nodule here, but it has widely invaded everywhere. here also, this is the main tumor, and it is going wide away into the adjoining tissues. So then we sometimes give you uncertain malignant potential. It on pathology means that even when the entire capsule has been examined, no complete invasion has been found. So this is not something which we can call as carcinoma. This is something which is called as uncertain malignant potential, where it should be based on full evaluation. It cannot be based on 2 slides, I see one focus, incomplete invasion. So this is the capsule, this thick, there is a thick capsule, and the tumor has only invaded midway. It has not completely gone out. So that is an uncertain malignant potential. You don't have to treat that patient like a malignancy, but you have to keep that patient on follow-up. There is a slim chance that this patient may have some potential for distant metastasis. So this is for the pathologist, and you also have to make sure that in follicular tumors, the pathologist has done extensive sampling, has made sure that he has looked at the entire capsule, and they don't need to take 20 different sections. It can be a lot of, the thyroid masses can be big, so they can submit the sections. This is for my pathology colleague. They can submit many slices in one cassette and reduce the number of cassettes. But it is still a lot of hard work evaluating a lot of the entire thyroid. The other is not only capsular invasion. The other way we can call it malignant is when we have vascular invasion. And that is an extremely important pathology factor, because we not only have to say, it not only gives you the diagnosis of malignancy if there is vascular invasion, but it also is a risk factor for distant metastasis if the number of foci of vascular invasion are 4 or more. So that is something that the ATA risk stratification tells you, that you also have to count how much vascular invasion is there. So you cannot accept the report of a pathologist which just says vascular invasion is present. You have to make sure that in follicular tumors, capsular invasion, widely invasive or not, that is mentioned, and vascular invasion, extensive or focal. They have written the foci are 4 and more or less than 4. Sometimes they will just write 4 or more or less than 4. But the counting of that is important, because if it is extensive vascular invasion, then it is a high risk of distant metastasis, about more than 30% risk of distant metastasis. Those patients will require radioiodine. So you will have to do total thyroidectomy, radioiodine, right? So this is what vascular invasion looks like. There's a plug of tumor in the. So the most important predictor of distant metastasis, and we have to quantify the number of foci of vascular invasion that are seen, because there is about more than 30% risk, and RAI is indicated, and it is a high risk feature. Whereas only limited vascular invasion or focal vascular invasion is a low to intermediate risk factor. So other factors will be needed to give radioiodine. So you check your report, it must specify the number of vascular foci. So about these follicular, we've seen that you require the whole capsule. So biopsy, frozen, cytology for follicular tumors does not tell you whether it is malignant or benign, because you need to see histopathologic invasion and invasion, right? So coming to the aggressive types, this also you should be familiar. One of the most important aggressive histologic type, this is in papillary thyroid carcinoma, is the tall cell variant, where the tumor cells are quite tall, much tall, and there is a criteria for that. The tumor cells are 3 times taller than they are wide. And the tumor cells, the tall cells have to be quite substantial. They have to be more than 30% of the tumor should be tall. So the WHO as well as ATA recommends that as the tall cells increase, the risk also increases. The risk of recurrence also increases. But it is this 30% cutoff, which is taken as now this is very significant, and these are associated with aggressive behavior. So tall cell subtype of papillary thyroid carcinoma, you can ask your pathologist to quantify how much is the tall cell percentage. Less than 30% is not labeled as tall cell. Up to 10 to 30% can be labeled as PTC with tall cell features. It is just to give you anxiety that these patients can recur, but it is tall cell subtype 30%, and it is an aggressive subtype. It is a risk modifier. So if you have all the other features are low risk, but this patient has tall cell, then also it fits into intermediate high risk. So in the ATA, I'm sure you are all aware of the ATA 2025. Now the intermediate category is intermediate low risk and intermediate high risk. And this goes and sits in the intermediate high risk. So most of the tall cells will also have other features like extrathyroidal extension. Most of them will have lymph node metastasis. Most of them will be multifocal. So it is very rare that you will have a very small tall cell, and then you have to decide whether RAI has to be given or not. But ATI is something that gives, it's a risk modifier. Now your risk has changed. It is, the patient has. And if you're thinking of doing an active surveillance for a tall cell, then probably it is not, then you need to escalate. The other aggressive subtype, which is very uncommon, is the columnar subtype that again the pathologist has to identify. And this looks less like PTC, it looks more like colonic colonic tumors. And this is also aggressive, and it has a 30% cutoff, intermediate high risk. Another one is diffuse sclerosing papillary thyroid carcinoma, again very rare, but that is a carcinoma that will involve the whole lobe. It is not a small tumor. It is a tumor that involves the whole lobe. That is why it is called as diffuse. It is a difficult diagnosis even for pathologists who have not seen too many of these, because it is uncommon. So, but diffuse sclerosing is, because most of the papillary thyroid carcinomas are squamous cells, but the grading tells you how bad it is, how far away its differentiation is. Well differentiated are the ones which are slow growing, are much better than the poorly differentiated ones. And most of the times we are giving grading also in the biopsy, but it is not mandatory, not mandatory. If it is poorly differentiated, we usually try to give. If it is moderate, well differentiated on resection, you may find worse areas and call it moderately differentiated, or you may find more worse areas and call it finally poorly differentiated. So the best grading is done on the resection specimen when you've seen the whole tumor. Biopsy is just a snapshot, so even if we don't give grading, the pathologist should at least single out that it's not poorly differentiated. So well and moderate are kind of, you don't have to, and you don't have to change your management based on well, poor or moderate. But oropharyngeal biopsies, P16 HPV testing is now part of routine, it is required. So if we don't have P16 IHC, we should work towards that, because now the staging of oropharyngeal squamous cancers is based on HPV type or non-HPV. Vast majority of our cases are non-HPV, so we don't feel the need, but it is required. The staging for HPV are different. Their response to radiation is different. Their prognosis is different. So AJCC now classifies HPV, the oropharyngeal squamous carcinomas, into HPV positive and HPV negative. And P16 immunohistochemistry can be done to say that this is HPV positive or negative. So vast majority are tobacco driven, smoke driven and all that. So we don't have that much HPV positivity. We have only about 6 to 20%, that's it. So most...
Ma'am, you nicely covered every aspect. I must congratulate you. Everybody was patiently listening to you. It was a very nice lecture. It was a very nice lecture. Just few questions I wanted to ask. Sometimes we get repeatedly that AUS category on FNAC or suspicious lesion, and patient not willing for surgery or something like. So can we do molecular testing for better categorization of these lesions, or can we do different, like whether it is benign or malignant?
So most of the times we don't need, in 90% of the times we don't need to do any molecular testing, but this is the specific category. When you are repeatedly getting AUS and you are worried, and your sonography is also not telling you whether you should go ahead and operate or not, Those are the indeterminates, and the patient is not willing for surgery and is rich enough, has deep pockets to pay for molecular testing. Then this scenario, it can help you decide. If it doesn't have any mutations, then you can observe that patient. But if it has some kind of mutations like BRAF mutation or TERT mutation or some kind of mutations which tell you this is malignant, then you will have to take counsel accordingly, right, and take a call of surgery. So in scenarios where the FNAC is indeterminate, you're repeatedly getting indeterminate, most of the decisions can be made by sonography, your own clinical judgment, and how anxious the patient is, right? So all these three factors will go into making decisions for AUS category. You've repeated, it's still coming. If sonography is telling you this is not a good lesion, you can operate that, right? But if your sonography is also very benignish, thyroid 3 and all that, then all those, but if the patient is anxious, or it doesn't want to do surgery, but you are feeling this could be, then molecular testing, definitely. This is the area where molecular testing in indeterminate thyroid cancer has to be done.
Ma'am, can we go for true cut biopsy from up in spite of molecular testing in this case?
In AUS scenario, don't do a true cut biopsy. Biopsy, because it will again give you follicular only. You'll have to take a call whether you will operate and do a lobectomy. You'll get a diagnosis. But if biopsy in an AUS will not give you a diagnosis, it will give you follicular lesion. We can't even distinguish follicular tumor from, I'll tell you from pathology point of view, you give us bone metastasis. It looks exactly like normal thyroid. Because it is in the metastatic site, we say it is thyroid carcinoma mets. So differentiated follicular thyroid carcinoma, when it metastasizes also, when it is malignant, right? It can almost look like normal thyroid. So it is very deceptively, so biopsy, unless we have that capsule and we can see invasion, the center of that follicular nodule versus outside, you cannot really distinguish. So in those scenarios where you are getting AUS, biopsy will not help you. Biopsy will help you when you are suspecting a lymphoma, anaplastic thyroid, medullary thyroid, and repeatedly you're getting FNACs and you're suspecting there is nuclear atypia on AUS. Those are the ones which are likely to be papillary thyroid carcinoma. But if it is right now we should classify AUS as nuclear atypia or architectural atypia. If it is architectural atypia, it is going to be this follicular lesion. You can do a biopsy, it may not give you, don't expect that it will give you all the answers in a follicular lesion.
So we have only two options, either molecular diagnostics or lobectomy.
But vast majority will be solved on ultrasound and how anxious the patient is and what is your clinical judgment. Many times you have repeated, but you think that this lesion doesn't look good, I should operate, then you can do a diagnostic lobectomy. But if you have facility to do molecular, it can help you. So, yeah.
Thank you.
Thank you.
And last small question, where frozen section can be used in thyroid surgeries? Like what are the scenarios?
Frozen section, again, for follicular tumors, do not, because we can't sample the whole thing in frozen. So for follicular, it has been, studies have shown it helps only in 4%, that you have sampled a nice invasion, right? So if grossly it is widely invasive, you will be able to get it on frozen also. But vast majority on frozen follicular lesions, no. But if you have a suspicious FNAC, they mostly are papillary thyroid carcinoma. Their frozen section can help you in suspicious FNAC. It can help you confirm if you are supposed to do total thyroidectomy and you just have a suspicious diagnosis. It's better to confirm on frozen, and then you're more aware that papillary thyroid can be nicely, medullary can also be diagnosed on, suspected or diagnosed on frozen, lymphomas can be picked up, and lymph nodes, mostly what we do is for lymph nodes, thyroid node metastasis.
Thank you very much for your so illuminating and informating session, ma'am, and your lecture was very interesting.
Thank you.
I think nobody will sleep even for 1 second. Now I would like to request our leading pathologist, Dr. Pankaj Goyal sir. Sir, please come on the stage and facilitate the mother, ma'am, as a token of our gratitude. Thank you, sir. Thank you, ma'am.